Thank you for the opportunity to present our research from the Division of Surgical Oncology at the University of Pittsburgh, a prospective study evaluating the impact of robotic surgery on functional recovery following pancreatic surgery. This research was supported by a robotic surgery research grant from SAGES. Robotic surgery has been shown to be a safe and feasible approach to pancreatic surgery at high-volume centers with similar clinical outcomes to the open approach. As robotics is growing in hepatobiliary surgery and multiple other surgical disciplines, we need a deeper understanding of its impact on patient-centered outcomes. While pancreatic resections are complex operations with high rates of morbidity and mortality, patient-centered outcomes are particularly relevant in cancer patients with poor prognoses. While physical activity amongst patients with pancreatic cancer is known to have a beneficial effect, functional recovery is not extensively studied. It can have implications on clinical outcomes such as complications, overall survival, and more importantly, quality of life. Therefore, the goal of this study was to evaluate differences in functional recovery and quality of life between patients undergoing robotic versus open pancreatic operations. This was a prospective, non-randomized, non-blinded observational study comparing patients undergoing robotic versus open pancreas surgery. Eligible subjects were adult patients undergoing elective pancreatic resection for benign or malignant indications. The primary outcome of interest was physical activity measured using a Fitbit, a commercially available wearable activity tracker. The secondary outcome of interest was quality of life, measured using the Functional Assessment of Cancer Therapy for Hepatobiliary Cancer, or FACT-HEP, a self-reported survey which is composed of subcategories including physical, social, emotional, functional well-being, and hepatobiliary specific symptomatology. Patients were recruited out of the surgical oncology outpatient clinics where they presented for their preoperative appointment prior to surgery. Quality of life surveys were conducted in person prior to surgery and at 3 post-op time points, during the inpatient stay, at the first post-operative visit, and at 3 months post-op. Fitbits were distributed and fitted to each patient preoperatively to obtain a baseline activity level leading up to surgery and was continuously measured until 3 months post-op. Step activity was transmitted wirelessly via Bluetooth and Wi-Fi. Over 18 months, 116 patients were enrolled. 78% of operations were robotic and 22% were open. 67% of operations were Whipples, 28% were distals, and 5% other pancreatic resections. The overall mean age was 65 years and 49% were female. Robotic and open patients had similar age-adjusted Charleston comorbidity indexes, proportion with malignancy, and of those with cancer, there were no differences in the proportion receiving neoadjuvant chemo or the number of cycles of chemo received. Robotic patients were more likely to be younger and have a higher BMI. There were higher rates of ICU admission and morbidity amongst the open group, with 35% experiencing clavien grades 3 to 4 complications versus 12% in the robotic group. There were no statistically significant differences in rates of pancreatic leak, delayed gastric emptying, or pseudoaneurysm, though there was a trend towards increased pancreatic leaks in the robotic group. There was 1 death in the open group within 90 days, 0 in robotic, and this difference was not statistically significant. This is a time series plot comparing average daily step count from day of surgery to 60 days post-op on the x-axis and average daily steps on the y-axis. The open approach is displayed in red and the robotic approach in blue. Step activity was, on average, higher in the robotic cohort and increased in a linear fashion compared to the open cohort. This is a display of quality of life score differences, where the horizontal 0 level represents baseline quality of life prior to surgery. Differences between baseline and quality of life as an inpatient is displayed in red, outpatient in yellow, and 3 months post-op in green. In both cohorts, we see an expected decrease in quality of life immediately after surgery in both cohorts. At 3 months, scores surpassed baseline scores in the robotic cohort, shown on the right, while the open cohort did not return to baseline, shown on the left. In the subgroup of HPB-specific symptoms within the FACTAP survey, robotic patients did significantly better than the open group. What's valuable about this data is what we can do to improve patient-centered outcomes. We have found a positive correlation between 90-day step count, shown here on the x-axis, with 90-day overall quality of life scores, shown on the y-axis, with a significant correlation coefficient. More importantly, we tested the correlation between preoperative step count on the x-axis and postoperative step count on the y-axis, and there was a positive correlation with, again, a significant correlation. Together, this information provides useful time points for designing future interventions and presents a unique opportunity to potentially intervene prior to surgery. In summary, following the open or robotic approach to pancreatic surgery, patients experience a significant reduction in quality of life during their recovery, which may not return to their pre-op baseline for more than 3 months post-op. The robotic approach may be associated with a faster return to baseline quality of life and improved HPB-specific symptoms. The robotic approach is associated with steady and linear improvement in objective step counts compared to the open approach. Higher steps correlate with higher quality of life, and preoperative physical activity is predictive of postoperative physical activity. In conclusion, the robotic approach to pancreatic surgery is associated with a steady improvement in functional recovery as measured by objective step counts and self-reported quality of life. Improving physical activity via pre- and post-habilitation programs may be a promising opportunity to improve patient-centered outcomes and quality of life in patients undergoing major abdominal surgery. Thank you to my mentors and all the research staff at the University of Pittsburgh. I also want to thank SAGES for their funding to make this research possible through the Robotic Surgery Research Grant. Thank you very much.